Our next speaker is Dr. Steve Little, who's one of our faculty here. Steve's done a lot of very original research and is a leader in our imaging, and as Dr. Barker mentioned, he's very active in all these leading edge programs here, so we're going to have a very interesting talk from him about a topic that is my number one source of begging for help and continuously rebuffed.
Thank you, Gerald. Okay, so it's always tough to follow Dr. Barker. He's got some amazing slides. All right, so we're going to move about 2 centimeters to the right, or 2 inches to the right. We'll talk about the tricuspid valve and some of the novel stuff that's available for us. Okay, tricuspid valve. So that's my only disclosure, is that we are about to embark on this trial of the tri-line. The real thing I want to get onto this slide is last night we had a dinner conversation, and Steve Goldstein was mentioning he was recently in DC and saw a white squirrel. Took a picture of it, showed us on his phone, and he was amazed by this white squirrel. But I grew up in Canada, and we have lots of white squirrels. In fact, there are some towns, and I found this very quickly on Google, we actually have a white squirrel festival. All right, so Canada rules, maybe not always in the Olympics, but in white squirrels. The important thing to point out here, particularly for Dr. Martin, is that these are acorns. I knew the question was coming, so just acorns. Okay. So this is really what I want to cover in this quick talk. So we're going to talk about functional anatomy, particularly the tricuspid valve, some of the imaging challenges, a few novel interventions, and then really I'll show you a case. Okay, so this is the way the books show the heart. We see this nice circumferential sort of LV. This is one way to think of it as a donut. We often look at the short axis, and this sort of very simply defines some of the challenges with the right heart is that a donut is easy, a croissant is tougher, and that's really what we're dealing with. We've got this crescent-shaped irregular chamber, which is just hard to be consistently imaged. The anatomy, and we've heard already about the complex anatomy of the mitral valve, it's just the same on the right side, but even more so. And some of the challenges are you've got, of course, the 3 cusps that define it. The size and the general proportion of those cusps can vary a little bit. But one of the challenges is if you try to find a cord-free zone and through the mid-belly of the leaflets, there's a lot smaller target. So some of the procedures we're going to talk about are really trying to get in there, use catheters to deliver technologies, recognizing that all of this web of cords you either have to sort of acknowledge or, frankly, try to avoid. So that's one of the big challenges. The elements of the anatomy, in terms of just nomenclature, this is, some aren't as familiar with how we call these cusps, but generally looking at the same orientation, the surgeon's view, we're used to seeing the aortic valve here in the center, and then we have the septal, the anterior, and the posterior cusps. Mitral valve is shown here, the annulus, and we've heard a lot about that, and sort of the saddle-shaped, very sort of a 3-dimensional normal configuration. Tricuspid annulus is a little bit bigger, still saddle-shaped. The saddle isn't quite as deep, but it has this important configuration where it actually folds to sort of provide some of the coaptation. Primary TR is a long list of things that cause it. The ones that we deal with the most are sort of pacemaker lead impingement and entrapment. Occasionally, a well-meaning heart biopsy comes back with some normal tricuspid tissue. And we've seen cords and leaflets come back, and that can be a real problem, particularly in the heart transplant group. And then we have the sort of the less common entities. The functional is really 90% of what we see, and that's functional TR. And the common pathway for functional TR is pretty straightforward. You can have chronic atrial fibrillation. You can have some form of left-sided heart disease that leads to chronic left atrial pressure elevation, and then a secondary increase in pulmonary venous pressure, pulmonary arterial pressure, and then RV dysfunction. Or you can have primary pulmonary disease. The common pathway is you get tricuspid annular dilatation, or you get subvalvular RV tethering of the leaflet, or you get both. And that's really how we get to functional TR. And functional TR is, as I said, about 90% of the TR that's clinically relevant. So the imaging challenges shown here. So this, how do we look at the tricuspid valve? Typically by echo. These are sort of the standard views. All right, so there's the scallops I've given you here, the septal, anterior, posterior. So the 4-chamber view is generally this cut. The 2-chamber view is this cut. The RV inflow view is this cut. But what I want to recognize is each one of those cuts will sort of regularly give you one of the scallops. So the RV inflow will give you the anterior plus one of the others, depending on your angulation. The 4-chamber will give you the septal plus one of the others. And the 2-chamber will give you the posterior plus one of the others. So that's one of the challenges is on the 2D echo is actually knowing what you're looking at. And this is sort of what you've got. So RV inflow is anterior plus one of these, septal plus another one, posterior plus another. So as we've gone through on the mitral side, you can do the 2D sort of trying to figure it all out. If the sonographer labels it, that's incredibly helpful. But thanks to some of the pioneering work that Dr. Lang has done, we know that 3D echo, much like in the mitral position, is sort of much more intuitive and easier to figure out exactly what scallops you're looking at. But the RV is at the front, the tricuspid valve is at the front. It's not always easy to get the same great shots you get of the mitral valve. So how does the dilatation occur? Shown over here, it tends to be in the sort of posterolateral free wall direction. That tends to be where functional TR manifests. So the challenges are real. It's tough to image the RV. It's tough also to image the tricuspid valve. Identifying the leaflets is even tougher still. And the quantitation is tough. So that's why it's been the forgotten valve intentionally for decades, because it's challenging. But we don't have a choice now. We have to pay attention to it because the technology from the left side of the heart is being moved to the right side of the heart, and there's actually a huge patient group that needs the attention. So you've heard already about the guidelines that came out last April. On the tricuspid side, you don't need to be able to read any of this. Really just to point out, much like the mitral setup that you've seen, there's several criteria that suggest it's a mild lesion, several criteria that suggest it's a severe lesion, and you've got the intermediate here, and another recognition that you might need alternate imaging if you sort of get down through this quantitation and you're not sure. One of the things to point out in relation to the structural world that we're now in is that when you get over into severe, everything is quantitated as greater than. So vena contractile width greater than 0.7, and EROA greater than 0.4, regurgitant volume greater than 45, and we don't know what happens after that. So that's really, I'll come back to that in a moment. So does the quantitation matter? Well, here's outcomes of clinical isolated TR. And this is a study that if you look back over several years, that folks who had their TR quantitated at baseline. So this green dot is the EROA greater than 0.4, so the current cutoff for severe. This is less than severe, and you see there's a huge difference in survival. If you break that down into those that are symptomatic and asymptomatic, so you get symptomatic on the right side, whether it's survival or sort of a collection of cardiovascular events, TR greater than 0.4 in relation to its EROA at baseline is a big prognostic risk, and it applies to symptomatic or asymptomatic groups. So bottom line, even asymptomatic TR is really bad over time. So we look at the guidelines that you've already heard about, and this is the specific chart on TR. What do we do? Well, this is, what I want to point out is this one. So we've got a few indications, class 2A. Class 1 indication is if you're doing left-sided intervention anyway, and there's severe TR, that's a class 1 indication. The challenge here is if you have preserved RV function with pulmonary hypertension that's not severe, there's a 2B, and as we heard, not the strongest recommendation, but it is a recommendation. The challenge we have is that many of the patients we see don't have preserved RV. So where do they appear on this decision tree? They really don't. So that's where we struggle is how do you deal with the people who have significant RV dysfunction, they may not have pulmonary hypertension, and they've got manifest right heart failure. So this is where we get into these interventions now. So the big interventions we have, you can sort of group them into several different anatomic categories. Those that do some version of annular modification, those that work on leaflet apposition, and those that really are sort of a caval implantation of a new valve. And there's several different sort of brand names, and much like what Dr. Barker showed you, there's a huge landscape in the tricuspid setting. There's a couple that I'll focus on that have had human clinical trials, but for every human trial, there's another 5 devices that have only been so far tested in animals. So there's a massive investment in the technology, and that's because of the perception of the massive clinical need. Okay. So sort of big categories I've shown you. This is one neat device. This is the Fortis device by Edwards. This is really, it's a coaptation device, but it's really a spacer. It just sits in that tricuspid annulus and provides a surface that the leaflets can oppose against. So it kind of fills the hole of the anatomic area. You've got this notion of putting, whether it's a specifically designed device or even adopting one of the Sapien TAVR devices and putting it into the cava. And then you've got these other devices over here that I'll show you some slides on that actually create an annuloplasty. That's sort of big categories. The anatomic challenges, again, are that the annulus is very large. It's non-planar, as I showed you in the beginning. There's no calcium. So unlike the mitral side, or unlike really the aortic valve, you can't design a device that's just going to grip a calcified annulus, because there's almost never any significant calcification on the tricuspid valve. You've got the RV, which I showed you is a very irregular shape. And then you've got all these other structures in the area that matter. The coronary sinus, the AV node, the vena cava itself, and the right coronary artery. All of those anatomic features make sort of the simple deployment challenging. So this is the Forma device. It's a pretty simple, cable directed device. It has this little grappling hook that just sort of holds itself into the RV apex, and it simply occludes the hole. Doesn't do anything to RV function, doesn't really mitigate in any direct way the amount of TR. Early human studies have shown that yes, there's an increase in exercise capacity and a quality of life. To date, no clear mortality benefit. To date, still undergoing trials, not FDA approved. This is a fascinating concept. This is an angio before and after an IVC stent. So here you can see the angios in the RA. There's a huge amount of hepatic flux. All of this is the TR coming from here across and then down. And this is the deployment of a stent within the IVC. The concept being you take away the V wave. So all that systolic flux back towards the hepatic vasculature is gone. One of the challenges is that you don't really do anything to the RA pressure. So you still have this diastolic gradient you've got to still overcome to get the flow back in. But at least taking away the V wave, and there's evidence that this, in a very small setting so far, can be beneficial for at least symptoms. And this is sort of what that CT looks like. This is another study where they sort of put cava devices in the SVC and the IVC. So there's a lot of interest here. We'll see if the physiology actually works out. The tri-line is probably the one that's furthest along. This is a catheter-based replication of what the surgeons do. It's a bicuspidization. So the idea is you using a catheter and TE guidance, you deploy a plegited suture here, and sort of the anterior annulus, another plegited suture here in the posterior annulus, and then you sort of externalize those wires and pull them tight, and you basically obliterate the posterior leaflet. So you bicuspidize what was formerly a tricuspid leaflet. That's the idea. That is a surgical technique, and this is sort of how it works. There's the catheter, and this is sort of the angios of what that looks like. And really all this is showing is the magnitude. These are the two plegited sutures. This is when they're pulled together. And now you've sort of really dramatically decreased the size of the effective area for the tricuspid valve. This is what that can look like. So this is a case with really no coaptation before. This is the tri-line deployed. That's the baseline TR, and that's the final TR. So it does work. The first-in-man studies have been performed. There was a recent sort of 30-case summary so far that was done and published with good results. No mortality benefit yet, but clear symptomatic benefit. And now we and other sites are involved in the pivotal study, the multi-center study, to see how good it really is. And this is sort of what the 3DT looks like. There's a very large, evident EOA, or actually anatomic orifice area in that tricuspid valve, looking from the RA down on the leaflets. And this is post-tri-line here. So you can see that the sort of posterior leaflet is gone, and the hole is much smaller, and the numbers are shown there. So an EOA reduction from 1.5, which is huge, because 0.4 is considered severe, down to 0.63, which is still severe. So it's less than half of what it was, but it's still severe. And I'll come back to that, because that's really is the frontier of the tricuspid valve. You can take away a lot of volume and still be severe. This is one of the reviews that's recently out that sort of looked at all this. Dr. Nishimura actually published a great recent paper on TR, an isolated TR, and he also has another nice paper in heart. So if you're interested in sort of reading a little more about TR, just look up Nishimura. He's got a couple of great ones. And this is just sort of, they're all first in man, basically. None of them are FDA approved outside of clinical trials. So to get us back in time, I'm just going to sort of fast forward a little bit and show you a case. This is a 77-year-old gentleman who was referred to us, complicated history of decompensated heart failure, refractory ascites, anasarca, really full-blown right heart failure. Medical history significant for gastrectomy, prostate cancer, hypertension, and chronic atrial fibrillation. His echo had preserved left ventricular systolic function, moderate to severe dilation of his RV, and severe TR. So I'll just let this play up and show you. So as is typical, the LV looks pretty good. Still has shortness of breath, and the physiology is often described as the septal being shifted, interventricular septum shifted by the RV dysfunction, creating both diastolic and potentially systolic dysfunction on the left side. This is his tricuspid valve. Yep. And there's a huge RA. There's no coaptation of the tricuspid leaflet. There's the color for what it's worth, but you don't need to do any quantitation. You know what's going on from here. There's no choice but to have severe TR. So he was a very high operative risk because of the comorbidities mentioned. We discussed a catheter-based intervention for this gentleman with using the tools we have today, and the tool we have today is MitraClip. The notion being, and this is again in that Nishimura review, how you might do it, and the idea is to not necessarily occlude or oppose all of the leaflets, but to sort of make a choice. In this case, in the graphic, the choice was to sort of clip together the anterior and the septal scallops. What we've done, because we have some experience in this, is do some 3D printing. Because we try to answer that question ahead of time, which scallops do we go for? You can't put clips everywhere. What's feasible, what's doable? So we've done some work where we take an echo, we sort of digitize the echo images, we do a digital replication of the tricuspid valve, and then we actually print the tricuspid valve. And we sort of, it's an anatomic, it's a soft deformable 3D print, and we can actually put the clips on and try to get a sort of an a priori understanding, where would this clip be most effective if we can get it on? And this is just showing sort of how we actually put the clips on, how the leaflets deform, and how we can look at these things from above and below and try to make some semi-educated choices before the procedure about where to target the clip. So here's this case. The left is looking at the tricuspid valve from the right ventricle. This is, and I'll put the labels on here for you. They should come on. There we go. So we have septal, anterior, posterior. And I think they should come up here. There they are, looking again from the RV side. And when you're new to this imaging, and I still feel I'm new to this imaging, you're always going back and think, which one is which? So the labels for me are very helpful. The labels clearly in the interventional suite are very helpful because everybody's confused about what you're looking at. So labels are key. So this was how we started. This was his TR at baseline. There's a long way to go to get these leaflets to touch each other. There's certain tricks that we've learned. Things like you can actually have the interventional fellow push on the anterior chest, kind of like half a CPR, and that will actually bring the anterior heart closer to the posterior heart, and that actually helps you with your tricuspid apposition. So that's a little technique we've recently heard about. We've tried it. We don't do it over and over again. We just do it once and hold it there.
How long is that? Half an hour?
It's, we choose strong fellows, and anybody who wants to apply. That's right. So,
The selection criteria.
yeah, that's right. They have to have one strong hand. So much like on the mitral side, we do the orientation in 3D. We do the tissue grasping in 2D, and that's because you need the temporal resolution of 2D imaging typically to achieve this. And this is sort of the tricuspid leaflet grasping with a MitraClip device. Dr. Barker would tell you about some of the imaging challenges because you don't have, you're not going transeptal, you don't have the septum actually supporting the catheter in the same way you do on a MitraClip. So technically it's, we sort of had to go through a whole new learning curve of positioning the device with different landmarks and different support mechanisms. So it's a device and a delivery system that isn't designed for the right heart. But at the end of the day, this is the clip deployed. You can see there's two big diastolic orifices and a much smaller systolic orifice. This is a short 3 hours later, and it felt like longer. And here's the clip on the tricuspid valve. If I showed the other one side by side, you would see there is a reduction in RV systolic function. That's what we expect to see when you take away the easy option, which is the RA. Yet there's an increase in forward RV flow, and we can talk about that. So this is the final TR severity. I always say the echo is still a little bit ugly. There's more regurgitation than we would like to see when you compare it to baseline. I think this should work. Oh, let's see, I want to get that to play. Okay, so there's before and after. You know, we sort of looked at this, and it's difficult now. You've got a device, and you're trying to quantitate this residual TR, but we called it moderate because we didn't know any better. But what's most impressive is what happened to this patient. This patient, we called it moderate TR in the end. She was in hospital, and this patient had a 30-pound diuresis over about 3 days. With no change in diuretics. It was the standard stuff that wasn't working, a clip, all the fluid came off. So that is what we tend to see. So if we get back to the guideline, and where the frontier is, it's what I alluded to earlier. It's not just the frontier in the devices that we have, it's the frontier in quantitation, and the frontier in prognosis, and the frontier in trying to figure out what to do. So, and I think what's been discussed recently is what's out here. What's to the right of severe TR? And the terms that I've actually seen published include massive TR and torrential TR, with a recent recommendation to add those into the guidelines. And what we're...
I'm not rewriting this.
Well, yeah, it won't happen this year. So do you rename the buckets? Do you rename what's in the buckets? I think that the important question that we haven't answered yet, but we're sort of getting little hints about, is if you know, will you achieve a mortality or a quality of life reduction simply by moving from one of these imaginary horrible buckets down to severe? And then maybe 3 buckets isn't enough. So we don't know, and I think that's one of the important frontiers in this field. So I'll stop there and get us back on time. Thank you.